Good morning, friends, on this Sunday morning. So today we are having the fourth edition of the Office Practice of Neurology, where we discuss mainly the issues which come up in the OPD and how we can resolve them. And today we have got two talks in this. The first talk is on facial weakness and pain, which is a very common problem. And to talk to us is Dr. Rajesh Benny. Dr. Rajesh Benny is a very young, brilliant neurologist, trained in JJ Hospital, Mumbai, and he is absolutely well versed with all the, issues of neurology and also the latest techniques of, how to access knowledge and how to analyze knowledge and how to, and he's one neurologist who worked throughout COVID times. I think he did not take a break of even one day. And he gave us a lecture also on that on the last session, that how to protect yourself while doing the OPD services. So over to you, Rajesh, on facial weakness and pain. You have about 20 minutes, but you can go for next 5 minutes also. Rajesh.
Thanks, Dr. Kaul, for that wonderful introduction. And we all know that.
Hello.
Can you hear me? Can you hear me?
Yes, we can. Go ahead, sir.
So facial weakness and pain is a very common feature by which patients walk into your OPD, and it's one of the most common symptoms after vertigo and headaches. And what we'll do here is to look at some basics which we may have probably forgotten, highlight some important pointers towards clinical diagnosis, and to look at some fun trivia about facial weakness and pain. So we'll start first with facial weakness. And it is one of the most commonly diagnosed cranial neuropathy which patients walk into the OPD with. We all know facial muscles are the primary mode for expressing emotions. It's a very important aspect of non-verbal communication and obviously a major component of beauty as we know it. Hence, probably it is more diagnosed, partly because it is so obvious to the patients and the social consequences that it carries. So this is a palsy which the patient doesn't sit at home with as compared to a hemianopia or even mild weakness where they tend to sit at home and feel it is just because of sleeping on that arm and they come to the hospital late. But a facial palsy patient will always find his way to you within the first 24 hours. What makes the facial nerve very vulnerable is it's got a very long intra and an extracranial course. We will see how is that. And it is important to remember that it makes 3 bends, of which one bend takes place in the brainstem and the remaining 2 takes place in the fallopian canal or the facial canal. And it is the nerve which has the longest intraosseous course. And probably the tightness of the canal and this long course makes it more vulnerable to unilateral or bilateral facial weakness. Now, I'll not go into the detail of the supranuclear innervation. We know that the upper half of the face is bilaterally innervated and the contralateral lower half of the face is bilaterally innervated, and the contralateral lower face is by the opposite supranuclear control. We will go to the pons where the facial nerve nucleus and the 6th nerve nucleus are close to each other. And here the facial nerve fascicles take the first bend, which is the internal bend, when it loops around the 6th nerve in the pons and it comes out of the CP angle till it reaches the internal auditory meatus. Till the time it reaches the internal auditory meatus, the motor and the sensory roots of the facial nerve are separate and they are with the 8th nerve in the entire path. The moment it reaches the internal auditory meatus, it enters the fallopian canal or the facial canal, which is a Z-shaped canal, which actually is from the internal auditory meatus till the exit of the nerve in the stylomastoid foramen. It's a Z-shaped canal and it has been divided for basis of understanding into 3 segments, both anatomically as well as functionally. And here is where the facial nerve takes 2 external bends. So the first segment is the labyrinthine segment. This is a segment from where the facial nerve enters the internal auditory meatus till the geniculate ganglion. Then it takes the first gentle turn, that is the tympanic segment. And the second turn, which it takes inside the facial canal, is a sharp 90-degree turn, which leads to the vertical or the third segment, which is the mastoid segment. And then it exits the stylomastoid foramen. When it exits the stylomastoid foramen, it divides into main motor branches, that is to the temporal, zygomatic, buccal, mandibular, and cervical, which supplies the various muscles of facial innervation. But there are other nerves which come out within the facial canal. And these are nerves which are very important to remember so that you can anatomically localize where is the site of the lesion. The first one is the greater superficial petrosal nerve, which arises from the geniculate ganglion and it goes to the lacrimal gland. The second important nerve is the nerve to stapedius, which arises from the tympanic segment, and this is the dampening muscle. That's the reason why you get hyperacusis in whenever this nerve is involved. And the nerve to cauda tympani, the cauda tympani nerve comes from the mastoid segment, which supplies the submandibular and the sublingual salivary glands, and also carries taste from the anterior two-thirds of the tongue. So this is the intraosseous nerve shown in much more detail. The first part is the geniculate ganglion and the proximal labyrinthine segment. The labyrinthine segment almost makes an angle of 135 degrees with the internal auditory meatus. And that's the reason probably why it's more likely to be injured at that side. This is the horizontal tympanic segment, and this is the vertical mastoid segment. But I'd like you to draw your attention to this small ganglion called the pterygopalatine ganglion or the sphenopalatine ganglion, which is very closely associated with the fifth nerve. So what is the connection between the fifth nerve and the seventh nerve is this ganglion, because the greater superficial petrosal nerve is connected also to the sphenopalatine ganglion, especially to the maxillary fibers. Now remember this point because it will give rise to some features which we see commonly in patients with facial palsy. However, we tend to dismiss that features. So who are more predisposed to develop low motor neuron cranial palsies? So those who are diabetics, pregnancy, elderly, the immunocompromised, especially HIVs when during the period of seroconversion are known to develop a low motor neuron facial palsy, those with malignancy, trauma, and in some patients, it can be familial. So these patients who have familial Bell's palsy or those with recurrent Bell's-like palsy tend to have long inter-attack duration. So one attack 20 years back, second attack probably 5 years back, and these patients may have a variable course. We don't exactly know the etiopathogenesis of this. Probably they may have an inherent narrow fallopian canal. Now, what is a viral pandemic doing during the Bell's palsy? I am very sure, like me, many of you practicing neurologists during this era are seeing dozens and dozens of Bell's palsy. Now, our rules here are very strict. We are not able to check COVID-19 without the classically fever, cough, and breathlessness symptom. And these patients are very, very stable. But I am sure that the virus is doing something to the nerve inside the fallopian canal. So here are some causes of facial palsy listed. I will not go into details of each and every one. So we have, for ease of convenience, divided into unilateral low motor neuron facial and bilateral low motor neuron facial. The most common is obviously the idiopathic or the Bell's palsy. You should not forget about otitis media, cholesteatoma, tumors like the meningiomas in the CP angle tumor or the neurofibroma. Trauma is an important cause. Sarcoid, very frequently quoted, very less seen. Leprosy should be a very important differential diagnosis in those presenting with facial palsy, and they have some peculiar patterns which I will show in some time. Herpes zoster and HIV seroconversion. The bilateral element palsies are the ones which you see with the GBS variants, HIV, vasculitis, leprosy, trauma. And then another entity which we tend to forget is the idiopathic intracranial hypertension. Time and again, we see patients who have got severely raised intracranial pressure, who have classical symptoms of papilledema headaches, and they tend to have subtle bifacial weakness. So this is because of pressure on the cysternal segment of the nerve on both the sides by the raised intracranial pressure. So whenever you are examining a patient with facial nerve palsy, the low motor neuron type, you try and remember some hints. So what are these hints? So whenever you see pain around the ear or around the mastoid, this is more commonly seen in patients with the Ramsay hand and the Bell's facial nerve palsies. But if you get pain elsewhere, say in the scalp, say in the neck, say in the jaw, then you're looking at something else. These are red flags. It may be a parotid tumor, it may be a temporal arteritis, which has presented as a facial nerve palsy. So this is the point which I was trying to come to when I was talking about the pterygopalatine ganglion. In many patients, in about 2/3 of patients with the so-called idiopathic facial palsy also, it tend to have subjective or in some patients even objective facial numbness at the paretic side. And this is more common at the V2. This is because of connections between the 7th and the 5th nerve through the greater superficial petrosal nerve. Whenever you see an isolated 7th nerve non-compressive neuropathy, you should not get any hearing loss unless if it is associated with the Ramsay Hunt syndrome. There are some unusual patterns of facial nerve involvement also. Just look at this photograph on the right-hand side of your screen. So the patient is trying to close his eye. There is a Bell's phenomena which you're seeing, but the orbicularis oris muscle looks all right. So it is just a branch which is supplying the orbicularis oculi muscle which is involved. And this facial branch nerve involvement is very typical of patients with leprosy and so also patients with tumor and trauma. So when you see a branched facial nerve involvement, remember these 3 DDs. Apart from the unilateral facial weakness that you see, you should also check for sensation over the concha. Now, concha is the hollow just behind the tragus of the ear. And in all lesions of facial nerve, you will see abnormality of the concha in some way or the other because it is supplied by the seventh nerve. So seventh nerve is also supplying the skin or the concha. If you have a lesion proximal or at the level of the geniculate ganglion, you will also have associated tearing abnormality and hyperacusis along with taste abnormality and xerostomia because of the involvement of the greater superficial petrosal nerve and the nerve to stapedius. If you have a lesion after the second external genu, that is after the tympanic segment, what you get is abnormality of taste along with xerostomia, but there is no hyperacusis or tearing abnormality. So these are some hints to tell you anatomically where is the lesion. So we look at some causes of facial palsy. And the most common unilateral facial palsy is the idiopathic facial palsy or the Bell's palsy, which we call very frequently. And this was described in 1821 by Sir Charles Bell's. But was he the first one to describe? By a far stretch, no. There were many others before him. Razi was a Persian physician way back in the 1st century, and he has described facial nerve palsy in great detail. In fact, he went to the extent to say that if there is associated hand and leg weakness, then these patients tend to have sparing of one part of the face. And if it is not involving hand and leg involvement, they can have involvement of the entire half of the face. So he actually made a distinction between supranuclear and infranuclear palsy. Nicola Frederick described that in 1798. Powell has described it way back in 1813, but it was Sir Charles Bell who actually published his paper. So it is very important to remove those cases from your attic and publish them before they are named after someone else. So we'll go on to some brief etiopathogenesis of Bell's palsy. Most of us are well aware of this. Like I said, this is brushing our basics. So it was in 1972 that a connection to herpes simplex virus reactivation started taking form, especially in those with Bell's palsy. And in as much as 2/3 of these patients, they found some seroevidence of HSV reactivation, be it from the serum or be it from the perineural fluid when these patients were undergoing facial nerve decompression. There are other infections which have been described in patients with the so-called Bell's palsy, the zoster infection, and other infections like the Epstein-Barr virus, influenza, etc., and probably even now COVID. The mechanism is direct inflammation or infection. So infections like herpes can directly involve the facial nerve. It causes edema, and because of the tight facial canal, especially at the labyrinthine segment, it tends to get damaged. In those with diabetes, the mechanism may be a microangiopathy, it causing a ischemia to the seventh nerve. And many of the patients who come to us with facial nerve palsy will tell that they slept nice in the night. When they got up in the morning, they noticed a facial weakness. It looks like a stroke. So probably it is like a stroke of the facial nerve. And in those who are pregnant, especially in the 3rd trimester or the 1st week postpartum, because of the increase in the extracellular fluid volume, probably there is increased perineural edema and compression in the tight fallopian canal. So the pathogenesis is not uniform. It is different for different entities. Do we do routinely an MRI in Bell's palsy? Obviously, no. You will do it to rule out secondary causes. So if you see a facial palsy progressing over 3 weeks, and if there is no improvement at all over the next 4 months, then you're looking at something else, better to do an MRI. And in most with the idiopathic Bell's palsy, you will get mild to moderate enhancement of the geniculate ganglion or of the labyrinthine tympanic segment, which is common. However, if you see enhancement of the inner ear structures along with enhancement of the facial nerve, you are sure that you're dealing with a zoster infection. Even if there are no vesicles, you can still label them as Ramsay-Hunt syndrome. So that's where the utility of MRI is. EP studies are not routinely done for diagnosis of facial palsy, and it is basically done to look at the prognosis. So if you have a CMAP which is very low, less than 10%, then the recovery is going to be incomplete and delayed over 8 to 12 months. If the CMAP is more than 30%, then of the normal side, then you will expect a near normal recovery in the next 2 months or probably even before that. The distal onset latency also tells us is the patient going to make a complete recovery or if he's going to left with some aberrant innervation and synkinesis. If the distal onset latency is prolonged when you do it between 5 to 7 days, then you may have good recovery, but a high chance of synkinesis. So EP studies have their role. So how do you treat patients with Bell's palsy? We know we treat steroids in all of these patients and it is mandatory and the doses should be adequate. Sometimes we give 10 or 20 milligrams. The dose should be good enough to tackle the edema within the facial fallopian canal and it should be started within the first 3 days. In those who have severe facial palsies, which is House-Brackman grading 4 or higher, there is some role to combine Valsivir along with the steroid for at least the first 7 days. I also try to use Valsivir in those who are diabetics or immunocompromised because we don't know whether they are dealing with an infective cause of Bell's palsy. There is neither any harm nor any benefit from electrical stimulation. Do not forget care of the cornea. A Bell's palsy will do very badly if he is an elderly. There is severe facial weakness. If the pain is pain other than the ear pain, if there is any involvement of the tearing change, that means the entire nerve is involved. If there are objective sensory abnormalities, especially beyond the concha, in those with associated hypertension, it has been shown to have a poor prognosis, and obviously the electrophysiological criteria that we talked about in so much of detail. And the last slide before we end the facial weakness is this typical patient who's got a painful right seventh nerve palsy of the low motor neuron type, and the ear shows this crusted vesicles, hearing abnormality, and this is the classical Ramsay-Hunt syndrome because zoster oticus, and that involves the seventh and the eighth nerve along with pain around the pinna. Now we'll go on to the next half of the presentation, which is on facial pain. And facial pain can be due to multiple causes. Dental is the most commonest. Musculoligamentous like TM junction is more common than neuralgiform, trigeminal autonomic cephalgia, and other syndromes. We'll try and look at these in some detail. So trigeminal neuralgia is the most common cause of facial neuralgic pain, and we know the classical description. It's an excruciatingly sharp, lancinating pain lasting for seconds, but mind you, it can go on for up to 2 minutes. And it is usually in the distribution of one or more sensory divisions of the facial of the fifth nerve, and usually around the maxillary division. Trigeminal neuralgia is more common on the right than on the left, more common in females, more common after the age of 50, and the second and the third segment of the fifth nerve are more likely to cause pain than the first segment. So if you get pain around the ophthalmic segment, you should start suspecting secondary causes. Most of these causes are idiopathic, and probable mechanism is a neurovascular conflict. And what happens is this pressure of the blood vessel causes a partial demyelination of the fifth nerve, and there is ectopic generation of action potentials. So whenever you see anyone with a sharp shooting lancinating pain around the face, you will start thinking first of local causes, dental TM joint dysfunction. And obviously if there are associated autonomic features, you look at SUNT or SUNA. We'll see that in some detail. And if you have a more widespread distribution of this paroxysmal pain, you will start thinking in terms of other trigeminal autonomic cephalgia like the chronic paroxysmal hemicarenia. So you start suspecting that it is dental when you apply pressure to the tooth, or if you percuss it with your hammer, or you apply the ice and you stimulate the same pain, then you know it's a dental cause, because the triggers can be the same. However, patients with dental cause of neuralgiform pain don't have any cutaneous triggers. And obviously you need a good dentist friend who can examine him and tell you that it is because of the local tooth problem. Burkiel et al. Is a neurosurgeon who classified trigeminal neuralgia wonderfully, and which also tells us about the pathophysiology behind the type of pain which the patient has. He divided trigeminal neuralgia as the classical trigeminal neuralgia, where more than 50% of the times they have episodic sharp shooting lancinating pain. And this pathologically is because of involvement of the large myelinated fifth nerve fibers. What happens if you have involvement of the small myelinated and unmyelinated fifth nerve fibers by that neurovascular conflict? And this will lead to the type 2 or the atypical trigeminal neuralgia, where more than 50% of patients may have constant pain. The pain may be burning type, the pain may be aching type, where you may falsely label them as an atypical facial pain syndrome or a psychosomatic syndrome. So trigeminal neuralgia is not only lancinating, but in about 50% of patients can even be burning, can even be constant pain. And even these patients do well with a trial of carbamazepine and gabapentin or pregabalin. So how do you diagnose trigeminal neuralgia? It's predominantly a clinical diagnosis with the classical description and the area of distribution. It should be considered in all patients with unilateral facial pain because it is such a severe pain that medication needs to be started as early as possible. And keep your eyes open to look for secondary trigeminal neuralgia by looking for red flags. So what are red flags? So whenever you have an objective sensory loss in a fifth nerve distribution, you're looking at a secondary cause. If there is associated hearing abnormality, you're probably looking at an early CP angle tumor. If there are associated long track signs like ataxia, weakness, or limb sensory weakness, obviously you're dealing with a secondary trigeminal neuralgia. If the patient is young, then you are looking at probably some other etiology. It may be a multiple sclerosis sitting at the root entry zone of the fifth nerve. And if you have an isolated ophthalmic involvement, which we have talked about. So the main crux of treatment in more than 90% of patients is pharmacological, and the anti-epileptic drugs are the cornerstone. There are multiple drugs which have been used, but the best response is to carbamazepine, so much so that response to treatment is believed to be diagnostic. And it is the only drug which has shown to be effective for trigeminal neuralgia in an RCT. So there are various other antiepileptics like oxcarbazepine, phenytoin, which are sodium channel blockers. There are drugs which act on other mechanisms like gabapentin, pregabalin, lamotrigine, and even topiramate. Sometimes we combine them with tricyclic antidepressants, baclofen, or opioids if the pain is very severe. However, try to look at some app to look for drug-drug interactions when you are going to use multiple drugs, because you never know, one may be inducing the other drug, and that's the reason why there is no efficacy. Surgical treatment of trigeminal neuralgia is considered in only less than 5% of patients. And obviously, you try and address the neurovascular conflict, and microvascular decompression is the most widely performed. But there are various other things like an ablative procedures which can be done. One of the problems with this surgical treatment, especially with ablative surgeries, is after a couple of months of honeymoon of no pain, you may actually get severe dysthetic burning pain with numbness in the area where the nerve has been ablated. And this is because of angry backfiring of afferent C fibers. So after trigeminal neuralgia, there are other neuralgiform pains which can also come from the trigeminal nerve distribution. And the most common of this is the post-herpetic neuralgia, which is neuralgiform pain, which is persisting beyond 4 months after the rash. And this may take various forms in the form of sharp shooting pain, burning pain, dysthetic pain. And the treatment in the initial phases when the rash is still there is with acyclovir. And in those who become symptomatic for neuralgia, you use carbamazepine, gabapentin, pregabalin, and the other drugs which you have used for patients with trigeminal neuralgia. Trigeminal neuropathy doesn't cause so much of pain, but it causes a lot of dysthetic or uncomfortable sensation around the face. There is associated numbness of the face with motor abnormality in the form of chewing or jaw drop. And usually it is seen in those with Sjogren syndrome or with underlying neoplasia. Trigeminal autonomic cephalgia is our primary headache syndromes, which we don't think about much in day-to-day practice because they are not as common as trigeminal neuralgia, but they are very important features, very important cause of facial pain. They share a common phenotype of pain which originates from the trigeminal parasympathetic vascular system. They have associated autonomic features in the form of meiosis, lacrimation, and rhinorrhea. And most of them will need an imaging to rule out secondary cause. So this is a primary headache syndrome which needs to be imaged before you call it primary. So what are the three core features of trigeminal autonomic cephalgia? You will have pain in trigeminal distribution. There will be circadian rhythmicity in some patients with trigeminal autonomic cephalgia, and probably this is because of involvement of the hypothalamus, and there are autonomic symptoms and signs. So the cluster headache is the prototype of trigeminal autonomic cephalgia. Here headaches tend to occur in clusters of few weeks to even months. They will always occur at the same time of the night or the day, and night times are more common than day. And there is a circadian periodicity. Means it's like an alarm clock headache. The patient will always know when the headache is going to start every day. So here the pain is usually unilateral. It lasts anywhere between 15 to 180 minutes. It is a severe pain, a suicide pain. It makes the patient very restless. This is one of the primary pain syndromes where males are more commonly affected than females, and there is associated autonomic feature. It is usually associated with REM sleep in about 90% of cases. Tobacco and alcohol are bad for cluster. A high altitude can trigger an attack. Probably hypoxemia plays a role in the pathophysiology, and that's the reason why there is rapid improvement in pain with high flow oxygen. There is no role for oral triptans. And if the patient is in the acute phase, you can try steroids. For chronic prophylaxis, verapamil. And in some patients who are refractory, nerve blocks can be tried. But this is a very disabling headache, and this is a pain syndrome which should be remembered as a differential diagnosis for those coming with facial pain. Paroxysmal hemicrania is another trigeminal autonomic cephalgia, which is far more uncommon, but there may be multiple attacks in a day, but they classically last between 2 to 30 minutes. So the outlier of pain for the classical trigeminal neuralgia is 2 minutes, and paroxysmal hemicrania starts after beyond 2 minutes to 30 minutes. They don't have any periodicity. There is no clustering of attacks. However, these attacks can be triggered by neck movements. And there is an excellent response to indomethacin. Other drugs like topiramate, calcium channel blockers, and even carbamazepine can be tried in these patients. Now look at this gentleman. He's an elderly man who's getting severe pain around the right eye. Yeah. And if you look very carefully, he's got some amount of tearing which is happening there. He's trying to sniff. There is some amount of lacrimation which is happening there, and there the pain is gone. So you ask him, is the pain gone? The pain is absolutely gone. So what is this headache? This is the SUNT, which is severe unilateral neuralgiform headache with conjunctival ingestion and tearing. And if there is no conjunctival changes, it is called SUNA. These patients can have multiple attacks. Durations can be in seconds. So they look exactly like trigeminal neuralgia. The triggers are like exactly like trigeminal neuralgia. But the important feature is there is a refractory period. Means for a trigeminal neuralgia patient, if the trigger is by touching the face, if you keep touching the face after an attack, there will be a period of refractoriness when you can't elicit the pain. But it doesn't happen with SUNT. You keep on touching it, the nerve will get triggered again and again, and you will start having those attacks. They respond best to lamotrigine, especially the SUNT. And if there are no conjunctival changes, probably there is some role that gabapentin is better than lamotrigine. Other drugs like carbamazepine and baclofen are also useful. These are unusual causes of trigeminal autonomic cephalgia. They have very mild features, the hemicrania continua, but they have a long duration of headaches. These can mimic migraine, but if you give indomethacin, they respond beautifully. But like I said, all TACs are assumed to be secondary unless proved otherwise by an imaging. And there are many tumors which have been associated with secondary trigeminal autonomic cephalgias, the pituitary tumors, phenoid ridge, or the CP angle tumors. And some of these patients may actually have a vascular loop, which tends to try and bring the same hypothesis of neurovascular conflict, like you see in patients with trigeminal neuralgia. Some patients have been operated on this. There has been varied reports, some with benefit, some with no benefit. So we don't know the exact role of these loops. So to summarize, trigeminal autonomic cephalgias are uncommon primary headaches. Pain is in trigeminal neural distribution with autonomic features. The clue to what is the type of TAC is from the duration of attack and response to indomethacin. So who are the indomethacin responder TACs? The paroxysmal hemicrania and the hemicrania continua. If it lasts for few seconds, it is SUNT. If it is for minutes, it is paroxysmal hemicrania. If it goes on for hours, it is cluster. And if it is for months, it is hemicrania continua. If you see periodicity with TACs, it is cluster. If there is an absence of refractory period, it is SUNT. And you need to always image these patients. Last two slides on patients who present with facial pain with specific etiologies. Temporal arteritis is the most common large and medium vessel vasculitis which occurs in patients who are more than 60 years of age. So it's an age-dependent vasculitis. And the most common feature is obviously headache. The classical description of headache is a temporal headache. However, it can be holocranial headache, diffuse headaches, jaw claudication, transient or permanent visual loss, constitutional symptoms, and polymyalgia rheumatica are very common in those with the temporal arteritis. Most common constitutional symptom is fever. So diagnosis is predominantly elderly in the appropriate clinical situation. You put your finger on the temporal arteritis and you feel a hardened, thickened, tender nerve and absence of pulsations in that temporal artery. A lab parameter which is abnormal, showing signs of inflammation. CRP is far more specific and sensitive than ESR. You can do imaging to try and look for the temporal arteritis. USG shows the halo sign, which is actually a thickened temporal artery surrounded by a hypodensity because of the inflammation of the vessel wall. And this has got almost 96% specificity for temporal arteritis, especially if it is bilateral. And in those where you are in doubt, you may actually do a nerve biopsy. However, you don't wait for the nerve biopsy to start steroids, because even if you have started steroids, which is the mainstay of treatment, and you do a biopsy after 3 to 5 days, the changes still remain. Any biopsy done after 7 days of therapy, you may lose the classical histopathological features. Methotrexate, MMF are used as steroid-sparing drug. And there is a mechanism of interleukin-6 mediated damage in those with temporal arteritis. Hence, this drug tocilizumab, which we are very frequently now using for COVID patients, is also used in those with refractory temporal arteritis. The last slide is on superior orbital fissure, where you see patients who come with pain around the eye, usually around the V1 territory, around the eye, around the forehead, and there may be multiple cranial nerve palsies. Usually it's a 6th cranial nerve palsy. So this is a painful cranial mononeuropathy. And these patients may have varied etiologies. In most, you usually don't find a cause. However, in some patients, it may be associated with the IgG4 syndrome, sarcoidosis, vasculitis, or malignancy. The orbital apex syndrome has all the features of superior orbital fissure syndrome, but it has the added involvement of the optic nerve. The cavernous syndrome looks like the superior orbital fissure syndrome, but it will also have an associated Horner syndrome, a proptosis, and chemosis. So these are all spectrum of the same longitudinal axis. If it is very anterior, it becomes the orbital apex syndrome. A bit back, it becomes orbital fissure, and a bit posterior to that, you see the cavernous sinus syndrome. So these syndromes have to be kept in mind, because many of the etiologies which cause these syndromes can be sinister, like venous thrombosis or malignancies. So to summarize, facial pain is because of varied causes. Dental is more than neurological. Trigeminal neuralgia is the most common neurological pain that you see over the face. A TAC closely mimics trigeminal neuralgia. In an elderly with facial pain, never forget to palpate the temporal artery. I thank you for your patient listening.
Thank you, Rajesh. I think that was an extremely useful lecture in our clinical practice. And you really gave some very important tips. I particularly liked to differentiate between dental and trigeminal by trying to press and elicit the pain. That was just wonderful. Only you could have done it. Thank you very much. After this, we'll have the next lecture and then we'll have the questions. Friends, it's my pleasure to introduce our next speaker, Professor Vivek Lal, Head of the Department of Neurology at PGI Chandigarh. Actually, Vivek Lal needs no introduction. Everybody knows him. He's a great teacher. I have myself witnessed. In fact, when he asks residents, he tells them, tell me this answer, otherwise I will throw you out of the window. And the residents are actually scared that he may throw them out of the window. But in this Zoom, they need not be scared because they are in their homes. But actually, he never throws anybody out of the window. The residents just dote on him. They love him all over the country. I know for sure that today, many of the doctors have come just to hear him have a glimpse of his personality and his lecture, the way he gets. He has a huge fan following all over the country. And even though he was my junior resident, I'm also one of his fans of his lectures, and that's a source of joy and pride for me. Over to you, Professor Vivek Lal, and you will be talking to us about no vision and low vision. Dr. Vivek Lal.
Can we start?
Vivek.
Yeah. The videos have been stopped. It's saying you cannot start because, yeah, that's it. So are you hearing me now?
Yes.
Yeah.
Yes, yes, Vivek.
Yeah. So morning, Suvash. Thank you so much for calling me.
So you'll have to share your screen.
Yeah, we're doing that. Yeah.
Yes.
Is it okay now?
Yes.
Yeah. Is it fine?
Yes, yes, sir. Go on.
So my topic, morning everyone. Thank you so much for giving me some time on this Sunday, and I'm going to discuss low vision and no vision. Right? And finally, we're going to come to normal vision. So the first thing that you do is, when you get a patient of visual loss, you have to ask yourself, is this visual loss unilateral or bilateral? Now, please remember, if the visual loss is unilateral, it means that it is involving the anterior visual pathway. If it is bilateral, it is involving the posterior visual pathway. The posterior visual pathways appear after the optic chiasma. It's important to remember that there are two types of visual loss, those involving the anterior visual pathway and those involving the posterior visual pathway. The one which involves the anterior visual pathway is monocular, and the one which involves the posterior visual pathway is binocular and hemianopic. Again, I further segregate visual loss into two types. Is it transient or is it permanent? Now, transient visual loss can again be monocular or can be binocular. If it is monocular transient visual loss, you're looking at an entity called amaurosis fugax. Now, please remember, all amaurosis fugax is atherosclerotic unless proved otherwise. Are you listening? Are you hearing me, please?
Yes, sir, we can.
All amaurosis fugax is atherosclerotic unless proved otherwise, and it is almost always monocular. Whenever you get binocular transient visual loss, you have got two possibilities to keep in mind. One is transient visual obscurations, and the second one is a top of the basilar TIAs or basilar artery TIAs. Now, if you have a young person coming to you with monoocular visual loss, which is very brief, which is lasting for a few minutes, please exclude the entity of retinal migraine. Classically, it is commonly seen in young women They have monocular visual loss lasting between 5 and 30 minutes, and that is followed by ipsilateral temporal headache. Now, what happens is often these patients do not complain of headache because they're not bothered about the headache. They're more interested in, and they're more scared of the visual loss. Hence, they will come to a doctor and complain of the visual loss alone. They will not talk of the headache. So it's imperative that if a young person comes to you with monoocular visual loss, which is transient and reversible, please ask for a history of ipsilateral headache to exclude retinal migraine. So that's what I'm trying to mean. That's what I try to mean when I'm talking of transient visual loss. Remember, it's very simple. Forget this table. If your transient visual loss lasts for a few seconds, please remember you are looking at TVOs, transient visual obscurations, which are often bilateral and occur because of papilledema due to any cause. It could be because of idiopathic intracranial hypertension, or it could be because of papilledema because of, say, a space occupying lesion in the brain. Transient visual obscurations classically last for a few seconds, whereas visual loss, which is atherosclerotic in origin, like amaurosis fugax, will last between 1 to 5 minutes, or maybe maximum 10 minutes. If you have got visual loss which is lasting between 10 to 30 minutes, then you're looking at retinal migraine. Amaurosis fugax of atherosclerotic origin does not extend beyond 10 minutes, and more than 80% of it probably finishes in less than 5 minutes, but it never lasts for a few seconds. It's always more than a minute. It's like a curtain falling in front of the eye. That's important for you to remember. If a patient is a diabetic and a hypertensive and comes to you with a monoocular visual loss, it is atherosclerotic ipsilateral intracranial carotid artery disease unless proved otherwise. And you must know that. You forget about anything else, treat and look for latent coronary artery disease in that patient. Whereas if a patient is young, say 15, between 15 and 25, I get to see so many patients who comes to me with monoocular visual loss, which is lasting between 10 to 30 minutes. First, make sure it is strictly monoocular. The next thing is ask for a history of ipsilateral temporal headaches, which you will get. It's retinal migraine. So don't put this patient on EcoSprint. You don't have to over-investigate this patient, but the other one needs to be over-investigated. So let's now go to a few clinical case scenarios that we routinely get to see. This is a patient who's hypertensive and a diabetic, right? Now comes to us with acute visual loss in the right eye for less than a week. And this visual loss was sudden. Note, sudden, painless, and was noticed on waking up. The patient had a past history of visual loss in the left eye approximately 3 years ago. So then what's the database? Sudden, painless visual loss, right? In a diabetic and a smoker who is more than 50. You sure you're looking at AION in this patient? Please do not make the diagnosis of demyelination in this patient. You will rock the patient's boat. This is nothing but an ischemic infarction of the optic nerve head called acute ischemic optic neuropathy, anterior ischemic optic neuropathy. Now, what is the hallmark of anterior ischemic optic neuropathy? Notice very carefully that the hallmark happens to be altitudinal field defect. An altitudinal field defect does not occur in any other condition other than an ischemic infarction of the optic nerve. I have to date, in 30 years clinical practice, never seen an altitudinal field defect in any other condition. And when you look at the disc, you will notice one thing which stands out. It's a flame-shaped hemorrhage. Now, notice that if you are having a flame-shaped hemorrhage in a patient who has got disc edema, the odds are that 90 times out of 100, it is going to be AION. Remember, flame-shaped hemorrhages do not occur in optic neuritis. So please do not make the diagnosis of demyelinating optic neuritis, NMO, MOG, etc. if there is a hemorrhage visible in the optic nerve head. It has to be, made sure that you're not looking at AION in this patient, which is of more, it's more ominous than the other demyelinating counterparts. Because when a patient has got AION, it's because of an atherosclerotic it's an atherosclerotic disorder involving the optic nerve head. It also means that this patient is having intracranial atherosclerotic disease. And it also means the patient may be harboring latent coronary artery disease. So when you do the fluorescein angiogram in this patient, you will notice that these patients have got very clear hyperfluorescence of the disc, right? So this is a normal, normally fluorescent lateral half of the disc, and this is a hyperfluorescent disc, which is very obvious here. And you get flame-shaped hemorrhages here. So these flame-shaped hemorrhages are the clincher that you are looking at AION as the cause of visual loss. And the treatment of non-arthritic AION is to treat the underlying condition. You control the diabetes, you control the hypertension, and of course you put this patient on antiplatelet drugs. In contrast to non-arthritic AION, we have another entity called arthritic AION. I mean, that's vasculating. So this is a typical patient of a vasculitic AION. 56-year-old male comes to us with decrease in vision, has had 2 episodes in a duration of 1 month. The first episode involved the left eye 1 month back, and the right eye has now been involved for the last 1 week. And it is sudden in onset, and it is occurring on wake. It was noticed on waking up. He also has got a fever of 3 months duration, and he's also got decreased hearing along with headaches. Now, when you are having this conglomeration of symptoms and visual loss, obviously you are looking at something systemic. I mean, this is not a bland visual loss. This is something systemic, which is also producing fever, headaches, and decrease in hearing. So on examination, this patient is found to have a bilateral element 7th nerve palsy, which the patient never complained of. He only complained of 2 episodes of visual loss and has got bilateral temporal artery tenderness. The previous speaker very characteristically told us about an ultrasound to be done in such patients. But in addition, this patient has got pallor and pedal edema. So when you are having pallor, pedal edema, you are having bilateral temporal artery tenderness, and you are having fever with visual loss, you are clearly looking at a systemic vasculitis. So what do we have when you look at the fundus? You look at the fundus, you are having bilateral disc edema. Notice very carefully that this is pale disc edema. This is pale disc edema, and there is evidence of choroidal infarction. You're seeing the choroidal infarction in the right eye, and there are these choroidal hypofluorescent spots on the left eye, clearly telling us that this patient has got bilateral choroidal infarction, and there is some amount of the peripapillary edema, which is also causing severe ischemia of the retina. So when we do the fluorescein angiogram, notice very carefully, you are noticing these black spots, which are because of decreased perfusion of the choroid. And another very important finding that you must note is that the optic nerve head is not filling up. You notice in the optic nerve head, there is no filling. Now, when you have a patient where the optic nerve head is not filling up, it is vasculitic AION. If you are having a non-vasculitic AION, you will have some hypofluorescence, as I showed you in the previous patient. But when you are having absolutely no filling of the optic nerve head, this is arteritic AION. And what is the treatment of arteritic AION? Steroids. Then you do the biopsy, then you do the ultrasound. Time is vision in arteritic AION. You talk of time is brain. Time is vision in arteritic AION. Every moment where you delay steroids, you're letting the patient go to the edge of the cliff. The moment you suspect arteritic AION, pump him with steroids and do the rest later. So that's it. This is arteritic AION as compared to non-arteritic AION in the previous case. So we investigate after we have given steroids, you're getting the elevated ESR and all the things which you would expect a positive. Pianka is positive, and the renal biopsy shows a vasculitis, and that's the temporal artery biopsy, which actually was done later after the patient was put on steroids, but yet it is showing you a break in the internal elastic lamina, and there is extravasation of RBCs in the tunica media. Findings are suggestive of vasculitis. So all this can be done after you have, in India, we all delude with patients. I mean, you don't wait for investigations to come. By the time the investigations come, the patient would have lost vision in the opposite eye also. Treat in addition or before your investigations are coming. So that's what arthritic AION is, you put the patient on steroids, and the right eye at 3 weeks, you're getting to see optic atrophy. Optic pallor would be the right word, right? That choroidal infarction has reduced in size, but it is still there. And the left eye is showing a worse looking, a more ominous looking optic disc with no PL. Now, this is very typical of an arthritic insult to the optic nerve. Demyelination always leads to a complete recovery. Non-arthritic AION will lead to a residual damage, but there will never be no PL in a patient who's got non-arthritic AION. And an arthritic AION, no PL is often the rule if you don't treat properly. So let's move to the next group of diseases which cause acute vision loss. Yes, you said we're talking of low vision, no vision, and then we have normal vision. We'll talk about that. 26-year-old female comes to us with pain on eye movements and diminution of vision for 1 week. I mean, you all know I'm looking at optic neuritis. 26-year-old female, pain on eye movements, subacute to acute onset visual loss, right? The right eye shows a visual acuity of 6/60, and the patient has got an RAPD and defective color vision. That's an acute optic neuropathy. The left eye is normal. You look at the fundus, you're clearly seeing papillitis, right? And do the OCT, you may or may not do the OCT. If it is not available, don't run after the OCT. Notice that there is no hemorrhage. Optic neuritis classically never produces any hemorrhages, right? And when you do the visual fields, you're getting to see an absent visual field here. I mean, there's hardly anything. Evoked responses will show you the evoked responses are always prolonged. You will never get optic neuritis with normal evoked responses. So if a patient has come to you with optic neuritis and is having normal optic, has evoked responses, the patient is fibbing. It's hysterical monocular visual loss. Look elsewhere. Also note that if you have got a proven optic neuritis and the patient has got P100 latency which is elevated, it never comes to normal. You will always have an abnormal P100 for as long as the patient lives if you have treated the patient completely. Even if the vision comes back to 6/6, you will have some defect in the latency of the P100 latency. That's because demyelination is followed by remyelination. Now, remyelination is never perfect. You will get a vision of 6/6, but you will have certainly some defect in the form or in the latency of the P100 in the involved eye. I have seen patients, I repeat this, I have seen patients who recover, have a vision of 6/6, but have got no P100 in the involved eye. I hope I'm clear. This is an important legal point. So you must remember that you don't chase the P100. You chase the visual acuity when you're treating optic neuritis. So you do the MRI in these patients, you're getting to see enhancement of the optic nerve, thickening of the optic nerve, and this is isolated optic neuritis. I must share one thing with you. Ever since I've seen NMO-MOG, I've realized one thing, that not all patients of NMO-MOG have got a severe visual loss. So I think if you're getting isolated optic neuritis with a normal looking brain, it's worthwhile doing an NMO-MOG straight at the outset. It's important to remember this finding. Some patients of optic neuritis of the NMO-MOG category have got a low, have got a mild optic neuritis, mild optic nerve involvement, which might mimic demyelinating, which might mimic MS. So it's important that we exclude NMO-MOG in all patients of isolated optic neuropathy, right? So let's move on. We give methylprednisolone to this patient. When you give methylprednisolone, recovery is complete, but the patient continues to have an RAPD. That's what I was trying to tell you. An RAPD will definitely exist in these patients who recover completely. Let's move on now. This is another patient of optic neuritis, but here, when you do the MRI in this patient, the patient has got Dawson's fingers. So here it's a no-brainer. You're looking at optic neuritis where a patient has had multiple attacks of MS in the past. And of course, this patient needs treatment on a different scale as compared to the previous patient where optic neuritis was the harbinger of the disease. Here, the optic neuritis has occurred intercurrent with the disease. The disease has already got, established in the patient, and now the patient has come to us with optic neuritis. So the management in this group is different. We all know the management. You know the management better than I do. So let's now move on to the other group of patients of demyelinating optic neuritis, which constitute NMO and MOG. Right? It's important for us to remember, unlike the West, where optic neuritis because of MS is more common than NMO and MOG, in India probably, and we have published this in Neurology India also, the ratio is 4:1. So we get to see 4 NMO MOGs for 1 optic neuritis because of multiple sclerosis. In my experience, if you ask me what is my experience, I probably would have seen limited number of optic neuritis because of multiple sclerosis. I must have seen an overwhelming NMO MOGs, and I would not have seen many optic neuritis because of MS. But the important thing to remember is the treatment of both is different. The presentation of both is different. Let's have a look at this patient. 60-year-old female has 2 episodes of loss of vision, 1 episode 3 months back, which was characterized by left disc edema. Now that's the disc edema. And when you get disc edema, you have a white looking, white looking graph here, right? And when you give this patient steroids, the thickness comes to normal, green is normal, but notice that there is some temporal pallor which is left in this optic nerve on treatment with steroids. Now the patient comes now after the second episode, and in the second episode, she again has involvement of the same eye. This time when we do the MRI, we're getting to see intense enhancement of the optic nerve. We don't have the previous MRI that was done. The patient had, didn't have a dedicated orbital cut. And this is a fat suppressed image showing you a thickened tortuous optic nerve. Okay. Now this thickened tortuous optic nerve clearly tells you, and this is spanning multiple segments. This clearly tells you that this is not optic neuritis. Why this is not optic neuritis? 60 years age. Why this is not optic neuritis? More than 1 attack in the previous 3 months. She's had 2 attacks. Why this is not optic neuritis? On radiology, you're having a thickened cord-like nerve, which is involving both the orbital and the intracanalicula segment. Now, this is not the typical picture of optic neuritis. And when you see the visual acuity 6/60, you know that this is not optic neuritis, which is a harbinger of MS. This is an NMO MOG syndrome. So we have to treat for an NMO MOG syndrome, which we all know is different from treating of optic neuritis. Right? The NMO MOG, as you know, can be positive in 60%, best centers 70%, in 30% it is negative. Here it was negative, but it did not preclude us from treating this patient as an NMO MOG syndrome. The CRP was positive, and she was given steroids. The visual acuity recovered, but then the management here is not interferons. On follow-up, they have to be given rituximab or whatever suits you. And what the important thing is, not interferons. I mean, this is not multiple sclerosis. This is optic neuritis because of an NMO MOG syndrome. Right? So let's move to another patient. All these are patients which we routinely get to see on our office clinic. Another patient, 49-year-old lady. In addition to having 2 episodes of visual loss within a span of 6 months, she has got what appears to be an attack of myelitis. Right? So she had an episode of visual loss involving both the eyes 2 years ago. Then she had, progressive weakness of both the lower limbs of 1 week's duration. This is now when she has come to us, right? When we see her, we getting to see that she's got counting fingers close to face, and the right eye is also involved. Let's have a look at the photograph. Look at the fundus, optic atrophy here, and temporal pallor here. You notice very carefully now that she's got a thinned optic nerve here, and she has got intensely enhancing optic nerve on the left side. And this is starting right in the, intraorbital, intracanalicule, and into the intracranial segment of the optic nerve. So all the segments of the optic nerve are involved. Now, when all the segments of the optic nerve are involved, to the extent that you're also getting to see some involvement of the optic chiasma. I hope I'm clear here. You're seeing this optic chiasmal involvement. This is not demyelinating optic neuritis. This is an NMO MOG syndrome. And to further confirm the diagnosis, the NMO antibodies are positive, and this patient also had long segment transverse myelitis. Now, because she is 60 years of age, it is always prudent to exclude a paraneoplastic MOG or an NMO syndrome at this case. At this stage, we probably would have seen at least a dozen patients of NMO syndromes of paraneoplastic origin, right? And in some, they antedate the cancer, breast cancer specifically, and in some, they come in an established cancer. That is, the malignancy is already there and they present later. So that's important for us to remember. But the clue is that these patients have got a very typical radiology. They have a very typical presentation. Bilateral, sequential, severe visual loss, radiology showing, enhancement extending across all the segments of the optic nerve, and also involvement of the chiasma. This is something which does not occur in primary demyelination. So we treat as per international protocol. So that's important for us to remember that what is this timetable of optic neuritis? If you don't give steroids to these patients, I kind of get to see patients, very unfortunate, where a patient was given a diagnosis of optic neuritis, was treated as optic neuritis, and turns out to be a malignancy. Irrespective of whether it is optic neuritis, whether it is NMO, whether it is MOG, remember this table of 1, 2, and 3. All visual loss in optic neuritis will worsen for maximum 1 week. It will stay at its nadir for 2 weeks, and it will recover completely in the next 3 weeks. Any deviation from this norm is ominous. So if a patient is not recovering, for heaven's sake, look for a nasopharyngeal carcinoma, look for a CA cervix, look for a breast carcinoma, look for a primary CNS lymphoma masquerading as optic neuritis. Don't go and have your coffee because it is getting cold if a patient is not recovering. All patients of optic neuritis recover, and this is the timetable: 1 week, 1, 2, and 3. So a cycle of optic neuritis maximum should last 6 weeks from onset to recovery. If a patient is having another, which is say going beyond 2 weeks, and the patient loses vision and does not recover vision, it is not optic neuritis. It is optic neuropathy. There is a difference between an optic neuropathy and optic neuritis. Optic neuritis is one form of acute optic neuropathy, right? So how does one distinguish between ischemic optic neuropathy and optic neuritis? Very simple. Look at the age of the patient. If the age is more than 50, the patient is a hypertensive, the patient is a diabetic, this is ischemic optic neuropathy. If a patient is less than 40, does not have hypertension, does not have diabetes, the chances are that you're looking at a demyelinating optic neuropathy. The second thing I told you is examine the fundus. The fundus in ischemic optic neuropathy is always abnormal. By definition, it is anterior ischemic optic neuropathy, meaning thereby that the anterior part of the optic nerve is involved, giving rise to a disc edema characterized by flame-shaped hemorrhages and disc edema, something which I've already shown you in my previous slides. The defect is altitudinal. It is invariable that you will either have an altitudinal defect or you will have complete visual loss in the eye if it is a vasculitic AION. Vasculitic AION, you will have savage visual loss, one eye followed by the other, and you will have edema. In a non-vasculitic AION, you will have unilateral visual loss. You will have unilateral visual loss, altitudinal, slow in onset, but one thing is very clear. When you see the fundus, you will get disc edema, you will have clear-cut flame-shaped hemorrhages. Now, what is the difference between what is the difference between AION because of diabetes and AION say because of vasculitis? Not difficult to understand, not difficult to summarize. If you understood what I've said, arthritic AION will have signs of vasculitis, bitemporal tenderness, fever, renal involvement if it is because of ANCA, polyarteritis nodosa because of SLE, and other features. least elevated ESR, and these patients may also have a history of amaurosis fugax. Whereas in AION, which is non-arthritic because of diabetes, hypertension, generally systemic symptoms are absent, but they have got uncontrolled diabetes and hypertension, and they will have what is a disc with a choroidal filling delay. Whereas in arthritic AION, the disc does not fill at all. I have shown you both type of discs. No filling of the disc means it is arthritic AION. Delayed filling of the disc means it is non-arthritic AION. I want to show you some, some differential diagnosis. Time is short, so I'll try to skip over. Now, this is what my previous speaker talked of, superior orbital fissure syndrome. This is a differential diagnosis which we often get to see. 49-year-old army Jawan comes to us with pain on eye movements and visual loss of 5 days. The moment you have this kind of a history, pain on eye movements, visual loss, you immediately think in terms of, what looks like an optic neuropathy, rightly so. Now you have to decide whether it is demyelinating or whether it is ischemic. This patient also, has a diminution of vision in the right eye for the last 2 days. It was left eye, I'm sorry. So this is the history, visual loss, pain on eye movements for 2 days. So when you do the fundus examination, you get into see clear-cut disc edema. So when you do the fundus examination, what do you notice? There is disc edema. A. B. That this disc edema is clearly, it's hyperemic disc edema. There is no pallor of the optic disc and the vessels are very prominent. So the first thing that you do in these patients is an orbital fat suppressed MRI. So when we do the orbital fat suppressed MRI, we notice that there is a cysticercus sitting at the orbital apex. Now this cysticercus is leading to visual loss and is producing what is called a superior orbital fissure syndrome, which the previous speaker had referred to. So all patients of acute visual loss must undergo an MRI, plain plus contrast, dedicated, involving the orbit in a fat suppressed fashion. You must have the same radiologist for your patients. Don't send patient A to a radiologist sitting in one end of the city and then patient B to another radiologist sitting in the other end of the city. The radiologist should know what you want, the radiologist should know who you are, and the radiologist should know what you expect from his radiology acumen. So that is what we do in PGI, you all know that, right? So this is the cyst sitting there. We put this patient on steroids, and this is orbital apex cysticercosis, but recovery generally does not occur in these patients. Sometimes fulminant IH can present with acute visual loss. Please remember, fulminant IH is a very important cause of acute visual loss. Please remember, if a young woman comes to you with bilateral severe headache and visual loss with multiple hemorrhages seen in both the retina, right, and there is disc edema, for heaven's sake, do an imaging followed by a lumbar puncture. Do not think here and there of cat scratch disease and all that nonsense, which I must tell you is becoming more and more common because people want to play to the gallery and talk of exquisite things rather than look at what is staring at you. This is fulminant IIH, 24-year-old female, obese, increased headache, TVOs, diplopia 15 days. And within a span of 4 days, the patient becomes PL negative. Look at the sad story. PL negative within a span of 4 days after the onset of visual loss. Bilateral. Now, we subject this patient to optic nerve fenestration, right? You're getting all the signs of IH in this patient, tortuous optic nerves, dilated venous sheath, and you're getting, there is no evidence of CVT. The pressure is also raised. We subject this patient to, if I'm not wrong, we subject this patient to shunting. The recovery tends to take place, but please remember one thing, the treatment of visual loss in IIH is prevention. I repeat, it is prevention. Don't wait for it to occur. Don't wait for it to occur. If once it occurs, then it is very difficult to retrace it, right? it's prevention. You prevent visual loss in IIH, right? And I think that's another patient. This is cortical venous thrombosis. I think this is Astha's patient. And this patient was reported in the Green Journal of Neurology. The patient had acute visual loss because of headache and left transverse sinus thrombosis. There was a myeloid, there was a subhyaloid hemorrhage here. And this is also called Terson syndrome. And this was on the, this was on the cover page of the Green Journal. So that's something which one should be happy of, right? Finally, one last, I think I don't want to exceed my time. How many more minutes do I have? Do I have 5 minutes? Excuse me?
You can take 5 minutes, Vivek. You can take 5 minutes.
Thank you so much. Thank you so much. You're very kind. I'll come and give you coffee there. So this is what I want to tell you. Yeah. All acute visual loss is not demyelinating. All acute visual loss is not ischemic. Please remember the entity of infections. For as long as you are in India, please remember infections. Now, this is a classic case, and I must have seen 30 patients like this. 21-year-old female comes to us with sequential visual loss. 3 weeks, one eye followed by the other eye. And because she's 21 years, she's a female, you immediately think of a demyelinating optic neuritis. Correctly so. You put the patient on steroids. But when you give the patient steroids, the recovery generally does not take place in this patient. In demyelinating optic neuritis, the patient would recover completely. Here, sequential visual loss, 3 weeks duration, right eye, followed by the left eye. Given methylprednisolone, no recovery. Now, the moment you have a patient like this where you suspect optic neuritis, you give methylprednisolone, there is no recovery. Your antennae should kind of, they should look for other causes, right? Have a look at the fundus. This patient comes to us, in addition to optic disc edema, there is redness in the retina. There are hemorrhages, there is retinal edema. And when we do the fluorescein angiogram, you can see that there are hypofluorescent spots. And these hypofluorescent spots actually imply that there is some amount of retinal ischemia also, but it could also represent these hemorrhages which are lying here. And so you're having these hypofluorescent spots. What is important to remember is the moment you see this fundus, you know this is not optic neuritis. Optic neuritis never involves the retina. Optic neuritis is an optic nerve inflammation. So when you're having bilateral sequential visual loss in this patient and you're having this kind of a retinal edema with retinal, with optic nerve inflammation, you have to look for other causes. You do the OCT, you're getting to see, there's some fluid lying in the submacular area, right? And you are getting to see liquefactive necrosis of the retina. Now, this liquefactive necrosis of the retina is very typically seen in only one condition in the Indian context, and that is SSPE. So this patient was actually having SSPE, presented with visual loss, Subhash called, and when we did the EEG, the patient was found to have his reader marker complex. The patient went on to have myoclonus 6 months later. So we have seen more than at least 30 patients of SSPE who present with visual loss. And by the time they go on to get myoclonus and things like that, you will have clear-cut evidence of choroiditis in more than 80% of these patients if you carefully look for them. So that is subacute sclerosing panencephalitis. Finally, acute visual loss. This was my first CPC as a consultant. The patient came to the emergency, acute visual loss, 2 days duration, had severe headache, loss of vision in both the eyes, had a right third and a fourth nerve palsy, bilateral visual loss, and the CT scan. There were no MRIs at that time. I think I did the CPC in 1993 when I just joined as an assistant professor. And this showed, what is this? Can anyone guess? This is pituitary apoplexy. You're seeing a clear-cut, level here, horizontal level. So this patient presented with pituitary apoplexy and which led to acute visual loss and right third and fourth nerve palsy. So typically a pituitary syndrome, one should always remember these possibilities, right? And I think I have one last slide to show you. I don't want to waste time, right? Let me move on. I move on. Yeah, this is one last. Postpartum visual loss is a very important entity that you and me talk of. This is a 23-year-old female. This is the last slide, who delivered twins, right? And then what happened on the 4th day after, she had severe headaches, which are bifrontal throbbing, and she had nausea, vomiting, irritability, and phonophotophobia. What is important is, on the 4th day after delivering twins, she went blind, completely blind. So that's how she came to us, Subhash. And this is the MRI at that time. All we were seeing is some amount of ischemia here. This is a, a diffusion weighted image, some ischemia here. But beyond that, there was no evidence of CVT. Normally, when you get visual loss, you think of CVT in a postpartum state, but the veins were very well seen. We thought it's a sagittal sinus thrombosis, which is presented with visual loss in the postpartum state. There was no sagittal sinus thrombosis. When we did the angiogram, what we got was a typical picture which you will never forget. This is a basilar artery, which is as thin as I don't know what, right? This is very typically seen in RCVS, right? So this was RCVS, thin basilar artery. We put this patient on steroids. When we put the patient on steroids, that ischemia went away, and there it is. Now look at the size of the basilar artery. The basilar artery opened up. So this was RCVS that responded to steroids. And I think I end here. Thank you so much for your kind attention. Thank you, Subhash.
Thank you. Thank you, Vivek. I think that was as expected. Yeah, 1 minute. Yeah, as expected, as we knew. And I think there was a message for me particularly that don't go for coffee because it's getting cold. First, attend to your patient. Thank you very much. Now we'll go to questions. And there are not many questions, but I'll just start to both of you. Our questions, just give me 1 second. Question and answers are here. Yes, Rajesh, there's a first question for you from Rahul Kulkarni, that we had seen many bilateral facial palsies with dengue. Some progress to develop GBS-like illness. Similar pattern has also been described with Zika. So in the differential diagnosis of bilateral facial palsy, how commonly should we think of arboviral infections in India? Please comment, Rajesh.
Yeah. So during the Zika virus, especially from the French Polynesian islands, there was a paper which came out where they looked at the Zika virus infection. And these patients would have like an abortive GBS, where they had only bifacial weakness and some tingling paresthesias and weakness of the hands. During the Zika virus pandemic, we should call it a pandemic, though in India it was not widely tested. We did see about a dozen of such aborted GBSs, but we could never prove them. But Rahul's point is well taken, that in those with arboviral infections, even with those with dengue, we see patients coming with bifacial weakness, but however, they have some other associated feature in the limbs, either hand tingling, hand weakness, or leg tingling or leg weakness. So they are like GBS variants, which come with bifacial weakness.
So we should look for GBS and wait for follow up whether they develop that. Yeah, thank you. Vivek, there's a question for you. Why retinal migraine is unilateral unlike migraine aura? Because migraine aura.
Retinal migraine. Very. I mean, that's a very relevant question. Migraine aura arises from the occipital cortex, and it's a bilateral. Whereas retinal migraine arises because of ischemia in the retina, hence it is unilateral.
And how do you treat retinal migraine? How do you
treat migraine prophylaxis? It's important to remember the most important part of the treatment is diagnosis. If you diagnose it properly, treatment is not a problem. The problem is these patients invariably are given all sorts of funny diagnoses other than retinal migraine. Remember, monocular visual loss in a young female is retinal migraine unless proved otherwise. Reversible monocular visual loss in a young female. Now, we are talking of office neurology. In the office, if you get this kind of a patient, which says that between 10 and 30 minutes, I have these episodes of visual loss in one eye and then I recover completely. Even if you don't get headache at that time, you will have a history of headache coming at times away from that episode of index visual loss. So you give them anti-migraine prophylaxis. There was this question whether we should give beta blockers, whether it leads to optic nerve infarction. The answer is no. I always prefer beta blockers. I avoid calcium channel and I avoid, flunarizine and things like that, because flunarizine is known to cause weight gain, which is not a very good thing to give to a young female. So Bhashkal, remember that. So I would give metoprolol, I would give Ciplar, and I would also, if need be, give nifedipine 5 milligram TDS or BD, depending upon whether the patient has responded to Ciplar or not.
Okay. Thank
so
you.
important thing to remember is beta blockers are not contraindicated. The next thing which the patient asks me is, how long do I have to take treatment? Remember, retinal migraine is known to cause retinal nerve infarction in a few patients. Hence, I would give it for at least a year, at least 1 year. Please remember that. Right?
Okay.
And the role of ecosprin is debatable. I don't give ecosprin to these patients. I would just give them beta blockers and would give them nifedipine or another calcium channel blocker. That's important. I avoid valproate. I avoid these flunarizine because they give rise to weight gain. That's the way I do things. I'm sure Rajesh is from JJ. He would have a different point of view. I'm sorry, Rajesh. Morning once again.
Okay.
So, that's the
Now,
way I track it. Yeah, please.
that's fine. Next few questions are on NMO spectrum. Do we have
Yeah.
any use for quantitative estimation of anti-AQP4 levels? Quantitative or qualitative is good enough?
No, there's no end to technology. It's nice to know that quantitative estimation is taking place, but I really do not know whether it is going to alter the prognosis or whether it's going to alter the line of management. If you have picked up the diagnosis correctly, if you have suspected the diagnosis correctly, I think even if the NMO or anti-aquaporin 4 antibody is negative, the treatment is going to be like NMO positive. You see, there is no difference in the outcome between NMO negative NMO and NMO positive NMO. That's being proven now. So I see no reason why quantitative estimation should have a role. I hope I'm clear.
Okay. Yes. There's a question from Amit Kumar. Recently, he had a patient with both anti-aquaporin antibody and MOG, both.
Yes.
So do we need to alter the duration of immunomodulation in these patients who have got
Very
both?
well. I'm glad you asked this question, Amit. Morning. I'm so happy he's listening to me. He's in Kerala. He's a student of mine. I asked this question to Sean. Who's that fellow? Sean Pittock, right, in Mayo. He says if you get NMO and MOG positive both, then you treat the patient as the patient is clinically behaving like. So if a patient has got a cervical myelitis, then you treat him like an NMO MOG. But if a patient has a conus cauda myelitis, you treat him as a MOG NMO. I hope I'm clear.
Yeah.
Because conus myelitis classically occurs in MOG and cervical myelitis classically occurs in NMO. So if a patient has got both NMO and MOG antibodies positive, then see how the patient is behaving and treat him for that.
Yeah. Now
But
there's
the
a
important
question.
thing to remember, Subhash, now this
Yeah.
time is vision. The treatment of visual loss in aquaporin 4 and MOG antibody syndrome is plasmapheresis. If you have that, this is one absolute indication of plasmapheresis. Please remember, in Oxford, they only do plasmapheresis. That is where all the MOG antibody syndrome came from, right?
Okay. Now there's a question from Dr. Neha. Sir, in MOG optic neuritis, should we put patient on lifelong steroids and spare other immunosuppressants even after the first attack, or should we just closely follow them? No, lifelong steroids for MOG.
No. If a patient, now very good question. Look, this question is from, where's this?
Neha.
Yeah. Look, you get a patient of optic neuritis, you do investigate, you get a MOG positive. You will have to treat, even if the patient does not have a second attack, you will at least have to give immunosuppression or immunomodulation for 2 years. But I must tell you now here, please remember one thing. When I was a resident, I had patients of acute transverse myelitis, power 0/5. Now 15 years down the line, 20 years down the line, when they come to me on follow-up, I did see a few patients who came to me and who now have got NMO MOG. At that time, they had acute transverse myelitis, did not recover, now came to me with spasticity. But because that time there was no NMO, now there is NMO, I got that done, it was positive. But in between, they've never had a second attack and they never got any immunomodulation. You getting my point? No? They were treated as acute optic neuritis or acute transverse myelitis. But now that we have NMO MOG, it is advisable to give them treatment for at least 2 years. I repeat, 2 years. You cannot predict the future. You understand? You don't know whether this patient is going to have 1 attack, 2 attacks, or 10 attacks. All you know is there's a standard protocol given for management and you should treat accordingly. I hope I'm clear. And the answer is only steroids is harmful because steroids have got side effects. I hope I'm clear, Subhash. They'll give you your steroids to patient, they'll become your and my size. That's not right. Right, Subhash?
Yes.
You know, so we need to immunomodulate. We have to, because steroids are very powerful immunosuppressants, but they have side effects.
Vivek, there's a question that you talked about AION, but how do you differentiate PION from optic neuritis?
Subhash Kaul, I'm so happy you asking me this question. PION is always bilateral. PION occurs because of acute severe blood loss. I have seen only 5 or 6 patients of PION. One was when I was a resident, gastric ulcer, patient bled from a gastric ulcer. Dr. Sani told me that he's got a call from surgery. There's a patient who's woken up blind. I went to see that patient. The patient had bled from a gastric ulcer, had hypotension, had shock. When that shock was kind of taken care of, he could not see. I went and saw the pupils were dilated and the fundus had shown optic atrophy. This was within 3 days of his becoming, losing his, having hypotension. So that is PION. Secondly, it occurs after surgical loss in uterine surgeries, hysterectomies, or in patients who have got vasculitis, temporal arteritis. So the management here is different. PION is always bilateral. AION is almost always unilateral. I hope I'm clear, Subhash.
Yeah.
PION is bilateral, right?
Yeah, that's correct. I think that's a good point. Vivek, few people have asked the same question, that in the last case you showed of RCVS, would you consider press or posterior reversible encephalopathy? In the last case, postpartum.
Yeah, these few people seem to be very intelligent and they seem to have woken up well in the morning.
No, 300 people have listened to your lectures.
Listen, I did not consider press because I got to see basilar artery narrowing, which reversed. So I thought of RCVS. Understand? Suppose there was no narrowing, it would have been press, no?
Yeah. So the other question is that you gave steroids for this patient, but is steroids the treatment? Is steroids the treatment for RCVS? They say there is no treatment for RCVS.
There's this famous phrase I tell my students: no man should go to his grave without receiving steroids. You understand my point? Right? Okay. She was crying that I can't see my baby. And they were twin boys. So I knew the mother-in-law is not responsible for the visual loss. You understand my point?
Yeah.
They were twin boys. They were not girls. Otherwise, I blame the mother-in-law. But here they were twin boys here. And she was crying, I can't see my baby. So what do you do when a mother is crying, I can't see my baby? You have to do something. So I gave steroids. And remember the third shot, she recovered completely. And now she's absolutely okay. The last time we saw her was just 6 months ago. And she came for another problem. She came for another related problem and she had recovered completely.
Yeah. Okay.
Yeah. So I give Now tell me one thing, RCVS, how many patients have you seen from no PL coming to normal 6/6 in less than 1 week without steroids? Have you seen a patient like that? Let me ask you a question.
No.
No, then I give it.
Yeah. Okay. Rajesh, there's a question for you, Rajesh. Whether we should give steroids and acyclovir in Bell's palsy with pregnancy?
So even acyclovir role is not well known, and probably the mechanism that happens in pregnancy is slightly different from what you will see with the usual infectious or inflammatory. Here the mechanism is usually because of the edema, because of the pregnancy per se. So the role of steroids also in pregnancy is a bit debated, but I would definitely avoid acyclovir in these patients. I would use, if at all, prednisolone.
And is there any involvement of pterygopalatine ganglion also in these Bell's palsy patients?
It is not involvement of the pterygopalatine ganglion. Actually, the greater superficial petrosal nerve is connected to the pterygopalatine ganglion. And that's the reason why you get associated sensory abnormalities or pain or vague subjective phenomena around the V2 area, especially because it is usually the maxillary fibers which are connected to the pterygopalatine ganglion, which are connected to the greater superficial petrosal nerve.
Thank you.
There was one question. I will just take that. What are you doing with steroids in the COVID season? Like, I want to ask, are you seeing a lot of Bell's palsies during this season? Because
no,
at least, at least in this Maharashtra group of neurologists that we are of, many of us are seeing Bell's palsy. And even I am seeing Bell's palsy. I'm actively in a hospital which is admitting COVID patients. And every week we see 3 or 4 Bell's palsy. 3 or 4 in Mumbai is slightly high, especially in a private setup. And this is not the season where we will see a lot of Bell's palsies. So here in these patients, because we don't know now, after a year, someone will tell us that's a form of first COVID. We are doing X-ray chest, at least an X-ray chest, and asking for other constitutional symptoms. And if it is even slightly abnormal, or if there are any constitutional symptom in the last 2 weeks, we are avoiding steroids because I think it is form of first COVID.
Rajesh,
are you doing the COVID analysis, doing the COVID testing in these patients before you say?
our BMC is tightly governing who's to take and who not to test. They are not allowing us to do COVID. So we can't do.
Right.
Rajesh, I think steroids may not be contraindicated in suspected
Yes,
COVID.
ideally no.
Help.
Ideally no.
Yeah.
They will help. Ideally, yes.
Achha, Rajesh, there's a question. Should one give steroids in Bell's with diabetes mellitus? Do you do that? Diabetes with Bell's?
Yeah, I do give, but the dose I use is slightly different from the 60 to 80 milligram that I showed. And here I go by the severity of the facial palsy. If it is only House Brackham grade 1 or 2, who I know is anyways going to do well, I might as well not meddle with his diabetes. But if it is a severe Bell's palsy, I will give.
Yes. Rajesh, Japanese sometime back recommended acute facial canal decompression in severe Bell's palsy. Is there any role and do you do it?
No, sir. It is
in the acute phase, in the first 1 week.
No, sir. There is no role. Anyways, in the first 1 week, it is very difficult to predict. Even the most predictable parameter is the CMAP and the distal onset latency, which you're supposed to do on day 7. So it is too early to say that these patients will not do well. So
you have not done, you don't.
No.
And second thing is that, a small percentage, maybe less than 5% after, even at the end of 6 months, have got some residual facial weakness, which may range from mild to severe. Have you got their plastic surgery done as a cosmetic in these small percentage of?
If it is for vital functions like the buccinators, or if there is a lady who is worried about the smile, I have got it done. Otherwise, it is basically to take care of the cornea.
But does it work? Does the plastic surgery work in there?
Not so good, because these patients are by the time also developed synkinesis. So it doesn't work too well.
Okay. Thank you. Vivek, there's a question from your senior resident, Dr. Keyur Butch. Dr. Keyur Butch. He's asking you a question. Is the VEP ever abnormal in severe IIH or idiopathic intracranial hypertension? Can VEP be affected?
In papilledema, it is always normal. If it is abnormal in IIH, it means optic atrophy is setting in. I hope I'm clear.
Okay.
In papilledema, VEP is normal. If it is abnormal, it means that optic atrophy is setting in, and this patient now mandates surgical aggressive intervention.
So I think most of the questions we have covered. Thank you very much, both the speakers. It was a brilliant session, and hope to hear from you again in further sessions. Thank you so much. Thank you so much, Vivek. Thank you so much, Rajesh.
Thank you, Subhash, and thank you, Rajesh. Morning again.
Thanks, sir. Bye. Take care. Bye. Safe.
So I hand over to Sudhir for the next session. We went few minutes overboard, maybe half an hour, but I think it was worth it because we had a good discussion. Sudhir, please take over the Ashish talk. Sudhir? Hello, Sudhir?
Sir, I'll call him up.
Yeah. To introduce Ashish Atre.
Is he there?
Is he there, or otherwise I can introduce Ashish?
Yes, sir, I'm here.
Ashish,
I'm
Sudhir
here,
is not there, I think. So Ashish, we welcome you to our session, and we are looking forward to today's talk of new techniques in MRI for neurological diagnosis. And everybody knows Ashish. I already introduced him last time. He's an eminent neuroradiologist, completely devoted, and he runs a star neuroimaging center in Pune and one of the excellent teachers in radiology. Ashish Atre, please.
Yes, sir. Two things. I'm just trying to share my screen. Okay.
So you have 2 devices logged in?
No, I have only one device logged in.
Mansi, that's Dr. Gursani, I think, who's logged in as, who looks like Dr. Atre on the name was Atre, but I think it was Dr. Gursani.
Okay, all right.
Share the screen, yes, okay. Oh, yeah. I came in through Ashish's link. Yeah, so that's why. Oh. So should I be exiting it? Or no. I will exit.
No, sir, I've changed your name. That's fine. That's okay. Hello?
Yeah.
Yeah, it's all fine. Only Dr. Atre has to just share his screen.
I'm not getting the screen share icon, so I'm searching for it. Somehow I started the video share and now I don't get the screen share.
So the same place where you started your video from, if you go back to that.
Yeah, I've gone back to that and share screen. Yeah, I got it.
Yes, sir.
Yeah, there you are.
So you do see my screen, right?
Yeah, yeah. We can
Yes.
see.
Okay. Just a sec. Okay. One thing before we start, I just wanted to check, since we are late, do we want to convert this into a kind of a lesser time for answer by using that single sequence? And that essentially you get to see the videos or